what's idiopathic intracranial hypertension? A lot of you are familiar with the term pseudotumor cerebri. Now, most recent years, the name has changed to IIH. So IIH is a condition where there is high pressure, high CSF pressure inside the brain, and it doesn't necessarily manifest as hydrocephalus. It doesn't manifest as buildup of fluid that you can visibly see in the scan. It's just a lot of pressure, and the ventricles, or the normal fluid spaces of the brain, tend to be really small in most of these cases. And for a long time, we didn't know why that was going on, and hence the term idiopathic, key in medicine for who we have no idea. And so that's what was going on for a long time. And then over the years, people studied the pathophysiology behind IIH, and they saw that it's really a venous problem in the majority of the cases. So what happens is, if you have CSF, or the normal fluid space of fluid in the brain, drains into the veins. That's how it comes out. You constantly produce CSF, and it constantly comes out of your body through the veins. And so if you have a venous blockage, obviously drainage is not going to be very good for the blood, but also, most importantly, for the CSF. And that pressure will build up, and you end up with IIH. So if you can identify venous blockages in these patients, you can really release those venous blockages and allow the blood to flow away, and together with the blood, the fluid drains, and the patients can have decreased symptoms. But this is pretty much the pathophysiology slide that I was talking about. And there's several diagnostic criteria when it comes to idiopathic intracranial hypertension. So these folks have a high pressure in the ventricles. Their pupils, their optic discs, their fondi get enlarged because of pressure through the optic nerve. So that's CSF kind of communicates in that area, so it transmits the pressure in the eye, and an ophthalmologist can see papilledema, right? And this high pressure, which you can diagnose with a lumbar puncture, but this kind of is what papilledema would look like. And so you follow this diagnostic criteria. There's no single test that you do and you say, you have, we did an MRI and we found IIH. No, it's a combination of papilledema, elevated pressure, most of the times in the lumbar puncture, and a bunch of other very specific symptoms. And there's two presentations for these patients that are important. One is they have horrible, debilitating headaches. The second is visual problems, right? And the headaches, of course, can be life-changing, but most of the times they're not life-threatening. When it comes to pressure in the optic nerve, that can be extremely problematic. These folks can lose vision rapidly, and that can never be recovered sometimes. So it really is important, IIH, when it comes to vision more so than the headaches. Of course, the headaches are important, but when it comes to really doing something, the decision is very much contingent on the vision aspect. The workup is, there's several paths in the workup of this disease. We always do some sort of venous study, an MRV, and often a diagnostic angiogram if we're considering treatment. But we want to see why are these patients experiencing IIH. And if in the MRV we see venous stenosis, that's a very good indication that we can help them with endovascular treatments. If there's no venous stenosis and the medications, typically Diamox that's used to lower the pressure is not working, you have limited options at that point, and you might consider a shunt, which is exactly that. You place a thin catheter inside the fluid spaces of the brain, you tunnel it underneath the skin and then into the peritoneum, and there it drains, gets absorbed by the peritoneum, the fluid, and the pressure normalizes. So this is the classic old way to treat refractory IIH. So medications are not working, patients are losing vision, the headaches are debilitating. This is what you would do. We still do it in folks that we don't have a venous target, but this has gone down significantly now that we can address this endovascularly, because of course people don't want hole in their skull, they don't want a catheter inside the brain, they don't want a foreign body going underneath the skin that can get infected, break, all that stuff, right? So how do we address these issues when it comes to endovascular treatment? So we generally use the vein side. Of course, we're going to the artery. We cannot do, you saw in the live case how we did an injection and you could see all the blood vessels. If you let that injection run, it'll go into the venous face and you'll be able to see the veins. You cannot do the same thing with the vein. You cannot really inject contrast in the vein. You can, but the direction of the vein is not inside the brain, it's outside the brain. So you'll be injecting and it's going to be going the wrong direction, so you're not going to be able to see. So we have in these cases to access both the artery and the vein the artery, we inject and wait until it goes into the vein so that we use this as a roadmap to then navigate and then treat this pathology. And so you see in that area the blockage is indicated, and then you place a stent that opens up. In these cases, we don't have to use a balloon, contrary to the TCAR, for example, where you have a hard atherosclerotic plaque that you need to stretch open. The cause of the blockage in most cases is arachnoid granulations, which are normal tissue that's just protruding too much into the vein, causing this issue. By virtue of opening the stent, the radial force of the stent will just push everything open and give you a nice looking result. And this is pretty much what this looks like. You know, we have to go up into the jugular vein, follow the sigmoid transverse, go across the blockage and deploy the stent. And that obviously then looks wide open. And this is what kind of, you know, stents look like. We use stents that normally you'd use in the carotid artery. They're large stents. We use them also for the venous side. And I'll show you in a second kind of how we decide whether we stent somebody or not. But this is for example, this is another example from one of our patients. This 58-year-old lady, 10 years history of IIH. So very long history of IIH, refractory symptoms, kind of given up on the disease, learned how to live with it. And this is kind of what you look like, right? I wish I could point to it, but you know what? I'm going to walk to it. So you can see the disease. You can see the blockage right here. The stenosis right here. Right? Does that make sense? Yeah. So that's the stenosis right there. And so when you go across that area, and this is after you stent it. You see the difference? Yeah? I'm not making it up? All right, so this is kind of what the blood vessel looks when you deploy a stent. And that's the other side again. You can see the difference. And the stent really expands in there, opens that area, decreases that pressure differential. Now imagine this blood that's trying to get through that blockage, so it's backed up. Pressure gets a lot higher, and then there's lower pressure below there. Pretty much like a river, if you had, you know, an area that's tighter, you have backup of pressure behind it. And this is what we do to determine whether we need to stent or not, right? So we're looking at the screen and we're trying to determine what is the pressure inside the vein. And if the pressure differential where the vein is over 8 millimeters of mercury, that's a good indication to treat this patient. And here, I'll show you again. So you can see, for example, this is the pressure we were looking at, right? So and this is the spot where we were measuring from. And this is the area of the stenosis. So before the area of the stenosis, because everything is draining out into the jugular vein, the pressure is 36 over 38. Oh, it's not arterial, it's a venous pressure, right? This is fairly high pressure. Then you go kind of at the area of the stenosis, you're about 23, and then you go after the area of the stenosis, you're down to 20. So the differential is about 16 millimeters of mercury. So that's a really good indication to treat somebody, because obviously you have significant pressure differential in that area. So that's kind of what would tell us go ahead and treat this patient, right? So this was a disease that again was not accessible in the past, and now we've developed all these endovascular techniques to address it. It's very satisfying for patients who have headaches for a long time. Also, what we call pulsatile tinnitus. A lot of these folks can hear their heartbeat constantly from that area of stenosis, and once the stent goes in, that sound goes away. And it can have a very dramatic impact on them. But again, the big issue here is indications, right? So if you select the patients appropriately that have stenosis, that have the pressure differential, you'll have a good outcome. If you don't, and instead you more put venous stents in everybody, most likely it's not going to make a big difference. So like anything new, you got to be very specific and selective with how you select these patients. Otherwise, your outcomes are not going to be good. And with that, thank you, and I'll take any questions.